Alrighty, we'll go ahead and get started here. So this is concussion care sideline to sideline, or you can call it the concussion care continuum. Basically, we're going to talk about a couple of different things and just generally kind of go over some treatment, but talking a little bit about concussion and how it can be assessed, and we'll kind of go from there. So my name is Dr. Bryan. I am a board certified functional neurologist. I've had over 900 hours in the diagnosis and treatment of different neurological disorders and a whole bunch of hours in basically mild traumatic brain injury, concussion, and stuff like that. So that's many of those hours. I have a bunch of different certifications. Another one that is fairly important to this topic is being a certified chiropractic sports physician. There's not a lot of chiropractors in general who have the more advanced training, like the diplomate status, like I have. And there are a decent amount of people that have the certified chiropractic sports physician, but in general, like if you're somebody who is not in the Toledo area that's listening to this, those would be people that would be appropriate to go to when it comes to concussion. So, but I definitely appreciate having the chance to go through and teach you guys a little bit about this, and we'll kind of go from there. So some other stuff, just so you can kind of see some things. I've definitely written some articles and some local papers and stuff like that on this in the past. And then I had this other article that's over here that was in a local paper that was talking about myself treating another patient. So basically what it comes down to is that there's I'm covering up just because they're minors, covering up the faces there, but some different treatment that I've had and some success that I've had with some athletes, especially for some longer lasting types of symptoms and problems. So when it comes to concussions, one of the things to remember is that concussions is basically a multifactorial injury. It does need to be managed by a team of people. You don't want to just necessarily have one person doing it. You definitely need a team of people that are helping people out. When it comes to concussion, concussion in general is a traumatic brain injury that is some type of a traumatic brain injury that results in some type of neurological impairment. So typically what happens is that there's a rapid onset of a short-lived type of impairment of function. The complaints are typically basically going to be a functional disturbance rather than a structural injury. So what that means is that even though you have something like this, again, somebody that gets hit on the button and then maybe, drops afterwards, like they're knocked unconscious or something like that. In most of the vast majority of cases of concussion, it ends up being something that you don't see anything on a standard type of exam. Like you definitely aren't going to see it on an X-ray, and you're probably not going to see anything on a CT or an MRI. So there's a bunch of different things that kind of goes into it. So when it says that it's functional, it means that there's not like an aneurysm or a major bleed or something like that you might see on that. It would end up being a situation where you do the testing and a person has a problem doing some type of function, like, counting or, some type of thinking or whatever. And we'll go over the symptoms here in a second. But again, the thing that's important about concussion is that there's no perfect diagnostic test or marker that a clinician can really rely on to get an immediate diagnosis. In some ways, it is a little bit subjective. So it's something that a clinician is going to need to use their experience and their training in order to figure out whether or not a person has it. And then on top of that, afterwards, it kind of depends on their training on what you're going to actually do next. So we'll talk a little bit about that and what happens in the general medical model versus what could happen in like the setting of a functional neurologist or a chiropractic neurologist. So general things that happen with a concussion. So again, approximately 90% of people that end up having a concussion don't actually lose consciousness, even though that's the classic kind of thing that people typically think of. So you don't typically lose consciousness. The other thing is that the head does not need to be hit. So that means that, you know, you don't necessarily need to be like hit with a baseball bat or something to the head specifically. Sometimes things could actually be where you end up taking a hit to the body. So if somebody takes a hit to the body and they don't necessarily like fall and hit their head on the ground or something like that, you could end up jarring the head in that way or jarring the brain inside of the head in that way. And that can cause problems as well. The vast majority of people are going to recover within 1 to 2 weeks. So, and then, you know, so that's 70% of people are going to recover in about 1 to 2 weeks. And about 10% are going to take a little bit longer than 2 weeks. There's going to be a certain percentage of the population that's going to have persistent symptoms for even longer. And again, some of these, which I'll show you in a little bit, you know, there are some symptoms that, you know, again, last for months and even years in some cases. So in the general idea is that that resolution of the general features that you find is going to follow a sequential course. So again, things start to progressively get better where there's not as many headaches and there's not as many problems or, you know, whatever the specific symptoms that a person has. And it's going to gradually get better, not quite as affect the person as often, or maybe need a little bit more stress. So like a faster heart rate or doing some of the different things involved in the sport in order to actually bring out some of the concussion symptoms that a person has. But again, like we said, in some cases, some of those symptoms are going to be prolonged. This is just to give you an idea of what it comes down to is that this is not just a football type of a problem, right? This ends up being a situation where it's not just like high school, like, or American football, where you're going to end up having problems and issues and stuff like that in regards to the case. So again, you can see in some of these cases, sometimes it's going to be, you know, getting hit. So girls soccer is one of the things that is a high rate of concussions. And one of the things that you can see in this clip, and I believe in the other one beforehand, is that, you know, one of the things that's associated in soccer with getting concussion is actually closing your eyes when they go to head the ball. So the heading the ball isn't necessarily the problem. It's closing their eyes when they go to actually head the ball. When they go to head the ball, when their eyes are closed, you can end up having two players that might hit heads when they do it. You might not see somebody that's coming in. You might get tripped. You might fall, you know, different stuff like that. It's not necessarily the soccer ball bouncing off of somebody's head in a header that's actually causing the issue. It's the eyes closed. One of the trainings that I was at recently for somebody who does a lot of work with the University of Cincinnati is that when they found out some of the different things about the eyes closed, they basically went through the pictures of all of their, basically every picture that they could find of one of their female soccer players heading a ball. Every single one of them, she had her eyes closed. So it didn't matter who it was. There were obviously multiple different people that were doing it, but every single time the eyes were closed when the person did it. So again, that creates problems. So when you talk about the football problems and what this injury rate means is that, so this is the injury rate per 100,000 player games in high school. So what that means is that if you ended up having 20 players and they ended up playing 20 games, that would end up being 500 player games. So the general idea is that out of 100,000 player games, you're going to have 47 concussions would happen in football, 36 in soccer. And again, you can see football, boys soccer, again, football, girls soccer, boys soccer, girls basketball, wrestling, basketball. So again, there's a bunch of them that's there. Girls hockey isn't actually included in that. And girls hockey is one of the highest injury rates that you have. It doesn't quite beat football in the number of concussions that happen per year. But if I remember correctly, girls hockey, women's hockey is one of those kind of things that's fairly high out there. And you'll notice that, again, when you look at something like this, girls soccer ends up having more than boys soccer. And you also notice that girls basketball also has more than boys basketball. And the general thought on this, and it's not absolutely 100% confirmed, but one of the general assumptions as to why this kind of stuff happens is that the muscle mass of the players has a lot to do with it. So the boys may be a little bit bigger in some of those cases, but the girls so like something that's larger hitting something else is going to create a bigger hit. But when it comes down to it, so like in boys basketball, an example would be like someone setting a pick. If someone sets a pick and somebody doesn't necessarily see it and then they collide, and they go down from that, again, that could end up being problematic. And obviously contact and other kinds of stuff. So, but one of the reasons is because in general, the female players have the tendency to maybe have slightly weaker neck musculature. And if they have slightly weaker neck musculature, that could be where the head is going to wobble a little bit more and cause more of the general sloshing around in the head of the brain. So that's the general kind of stuff that happens with that. Obviously, there's other sports where things are going to be, associated with concussion on a regular basis, obviously boxing being one of them there. So in general, though, when you talk about concussions and the major causes of concussions, again, obviously, there's some sports that have a lot to do with it. But in general, high school sports and stuff like that isn't up at the top of the list. In reality, concussions are going to be caused mostly by falls. But then you also have car crashes, which is something that chiropractors deal a lot with. So many chiropractors deal with concussions on a regular basis. Not all chiropractors have the right training in order to identify and really treat concussion, because they a lot of times might just treat some of the neck issues, but the concussion isn't going to be something that they might be able to deal with. Workplace accidents, assaults, and other kinds of stuff. So again, there's a whole lot of different things that can end up causing concussion. When it comes to the symptoms that are associated with concussions, the symptoms have a whole range of different things. And again, every individual is different. So you end up having, this, list of 20 something, maybe symptoms that are here. And again, some people will have dizziness. Some people will have headaches. Some people might have vertigo. Some people might have tinnitus. There might be blurred vision in some, fatigue in others. And again, everybody's a little bit different. Some people might have nausea. Some people might have some cognitive impairment. There might be some memory problems. So again, each of these different things ends up being, problematic. So there's a lot of different things that could be the symptom of a concussion in a person. And some of it depends on your knowledge of the person beforehand too. So again, if you've never met the person, you're not going to notice whether or not there's a personality change. Maybe they're a little bit gruffer or meaner or something along those lines. And again, it could be because they have some irritability because they're in pain and other kinds of stuff like that. But there are multiple different things that are associated with concussion and the symptoms. So the thing is that it does get kind of difficult in some situations because it's hard to standardize care in some of these or standardize like the problem, because a person that ends up having vertigo is going to have different problems than maybe somebody that has just a slowing of their reaction time, right? Or a problem with processing information and how fast that they can process it. Right. So everybody has different. So there could be slightly different areas inside of the brain that might be dinged. So you end up needing a specific type of treatment for each of those. So when it comes to people who end up having concussions, depending on what it is that they're doing, obviously, if it's a sport, they should be removed from the activity. They should be removed from a sport. If a person is working, they should definitely be removed from the job if they end up getting a concussion. They need to be sent home. They need to be evaluated and that kind of stuff. A person who's doing it, and this isn't necessarily for this isn't going to be for a lay person, but a medical provider needs to document their status. Maybe do something like a SCAT-3 or some other types of sideline evaluations if it is football or something else. And then their personal medical provider probably needs to be notified pretty soon thereafter. Again, you want to monitor symptoms for 24 to 48 hours, make sure everything is okay, and kind of go from there. So, and that's the general kind of stuff. But beyond that, when it comes down to it, is that there's going to be some situations when a person is going to need to, like actually call 911. So some of those situations would be if the person loses consciousness. So LOC is loss of consciousness for more than 2 minutes. The loss of consciousness is not a common thing that happens, but anytime that somebody gets, knocked out and they're out for more than, 2 minutes, that's definitely going to be a time to call 911. And with any of these specific things, you would call 911. You don't need to have all of them. So if they have some type of immediate type of onset of a headache, and again, an immediate headache that starts to increase in intensity, that's going to be another thing that you can end up having a reason to call 911. Vomiting, if there's an open wound, if there's something that, again, stuff is in and that needs to be sutured or any of that other kind of stuff. Focal neurological deficits, which basically is like specific things like paralysis. They can't move something. Again, not just pain, but they can't move it because they can't control it. If they have a problem with speech, if they're slurring of speech, major problems with balance, those would all be reasons that you would want to call 911 and get somebody evaluated more quickly. Fluid discharge from the ears or nose. If you have fluid that's coming out of the ears, or if you have fluid that's coming out of the nose, and again, these would be things that would happen probably in something that's going to be a little bit more of a violent type of a collision. Those kind of things, it's not, like you don't want to take the chance of thinking that it's just a runny nose, especially if the person did not have a runny nose or something beforehand. That could actually be cerebrospinal fluid that is leaking from the brain from a skull fracture. So there's a handful of different things, and there's reasons to call. It's always better to call if you're not sure, though, is really what it comes down to. So that's basically that. But when they do go to the hospital, when you do it, there's basically a couple of different things that can happen. Really, the main question with that is that do they have any of these focal neurological deficits on an exam? And then on top of that, what does the imaging look like? So in some cases, you're going to end up getting imaging, and this is going to be, again, a diagnostic image. You're going to be doing something from the standpoint of, again, in a hospital. The main thing that they use in a hospital is typically CT scanning. They typically aren't going to really bother with x-rays unless a person is going to have, that might be something that might be a little bit quicker, but CT scanning of the brain, and then you can do the spinal cord as well. Or I'm sorry, not the spinal cord, but the cervical spine, including the spinal cord, would be another thing that you could do in order to monitor for fractures and other kinds of issues, if there was problems with the neck. So CT scanning is the main choice just because it sees bone really well. And besides seeing bone, it does see like the soft tissue stuff. MRIs are much better at that. It's seeing the soft tissue and the detail in the soft tissue, but it's typically not indicated in an acute setting just because of the fact that you're really trying to make sure that there's not a brain bleed or some other kind of scary type of a thing. But people that have gone and seen somebody for a concussion really need to be seen afterwards after they get out of the emergency department. So the emergency department may make some, prescriptions or something like that in order to help to try to mitigate maybe some of the symptoms that a person might have. But what it comes down to is that they're not going to be typically doing a lot of, long-term type of treatment in order to get a person better. So in a situation where a person got discharged from the emergency department, a lot of times they're going to want to go to a concussion specialist. And again, it's not just any medical neurologist or anything like that. You can, but I would say that somebody that's more specializing in concussion would be somebody that's appropriate. So again, a licensed healthcare professional with training and experience in concussion who sees a decent amount of those kind of cases. So again, if the person is specializing in MS, it's probably not necessarily the best thing to have them go to them for a concussion. But again, obviously doing different types of testing and stuff like that is going to be a major part of doing, of being a concussion specialist and figuring out what the problem is. So after you go to the ER, generally what happens is that the main kind of thing that people get told to do is rest. That's really what it comes down to, is resting until the symptoms go away. And that is the treatment. There is no very specific type of treatment for concussion in and of itself. There's some treatments for, like if you have nausea, they can give you something in order to make it so that you're not quite as nauseous. But there's nothing in order to make the actual pain get better. Or make the actual problem with concussion go away. So the idea is that after the person ends up getting injured, there ends up being problems with the amount of ATP, which is the way that the cells in the body and the neurons and stuff like that make energy. So, or that is the version of energy. So supplying energy to the system and the blood flow associated with the brain ends up being compromised or ends up being, like problematic. Again, that's not necessarily saying that the person has a stroke. That's just saying that there isn't going to be as good a blood flow through an area. And again, the idea is that when you wait, a lot of times the symptoms, again, person might get more symptomatic. Again, the social isolation ends up being an issue that's related to depression. And again, other stuff that's there, the anxiety and developing problems with driving. Somatization is basically where you're going to end up having the person, they can end up getting persistent pain that's associated with it, with the injury. So, and again, basically what it comes down to is that when they do the testing on it, there's not a lot of stuff that says that physical and cognitive rest is actually really beneficial, even though that's the main thing that people are going to use. So when it comes down to it, again, there is not a lot of evidence that shows that rest is going to be done the best. So the general idea is that there's insufficient evidence that the rest is going to help do that. So, and again, at the beginning, maybe at the first like 24 to 48 hours after an injury, rest can be a good thing, but a person shouldn't be on, bed rest for a week or anything like that. Again, patients can be encouraged to, again, gradually and progressively get a little bit more active while staying below their cognitive and their physical symptoms, like thresholds. So what that means is that if you sit on a couch and you stare at the wall, you don't have pain. But if you start to watch TV, your headaches get worse, then that's going to end up being a physical symptom exacerbation. If you end up having to, do your taxes right after, then you can end up having a cognitive problem because you can't pay attention or you can't do what it is that you need to do. So that would be an example. Again, taxes is going to be something that would be harder, but again, you might not want to do taxes, but, maybe doing, simple math to figure out problems, maybe that would be problematic. Maybe it would be fine, but you have to figure out what the person's thresholds are for that stimulation. Again, you wouldn't want somebody who's an athlete to do, right after a concussion, you wouldn't want somebody to do a lot of vigorous exercise right afterwards. Again, after a little while, for sure, you want to start to promote the person to move and stuff like that. But again, the exact amount of rest, the duration, that kind of stuff of rest is not really defined within the literature. So again, there's no single rehabilitation strategy that's going to be effective for all patients. So what that means is that you end up needing to have distinct type of treatments available for people. So when it comes down to it, again, there's a lot of different detours that you can take, but the typical kind of thing that happens in a medical doctor's office is that the person is going to end up being seen maybe 3 to 4 times, and just monitoring progress over 2 months. That's a lot of times basically what happens is that you come in, let's see how you do. We're going to do an exam. We're going to see how you're doing. right? If the person has pain, they might get some medication for the pain or nausea or, some of the balance issues, but that doesn't fix the underlying problem. It just basically helps to cover it up. And the idea is that if a person just, gives it enough time, they're going to get back to normal. And a lot of times that happens, but for too many people, they end up having no progress. So you end up doing, 4 visits over 2 months, and it just basically shows that the person didn't get any better. But there's not any therapy that was really given for people in order to get better. Again, that's some cases, it's not every single person, it's not every provider, but that's a classical kind of a thing, right? So people might have reduced like course load if they're in college, or a little bit less, maybe no sports for a month or whatever. They might be doing some conditioning and physical therapy. They might go to a psychologist for talk therapy or cognitive behavioral therapy. They might need to go to another specialist in like the Mayo Clinic or in the Cleveland Clinic or something like that. And in some cases, people do get referred for physical therapy, like specifically for it, or vestibular therapy, or they might go to a chiropractor. There's occupational therapists that do stuff. There's other things that happens with optometrists as well, that some of them are going to be doing some work with like prisms and other kinds of stuff like that. So there's multiple different types of treatments that are available. Now, when it comes to getting a person back, this is the general way that you're supposed to actually bring somebody back. Again, specifically talking about school, right? So the idea is that if like you're talking about a high schooler, is that you don't want to just throw them back in. You want to make sure that they actually can do some of the work and that they're not getting overloaded. Because that's the issue is that if you have a hard time focusing, let's say that one of your problems is changing your focus. Well, basically, if you're at school, especially imagine a sophomore in high school, basically you're at your desk, you're taking notes or you're doing homework or something like that. And then you have to shift from being, a foot or two in front of you to now all of a sudden looking up at the board that's 15, 20 feet away. When you go to look up at the board, you have to change that depth of field. You have to change your focus from being down to being up. And for some kids, after a concussion, that can maybe be problematic. So again, if you're constantly having to shift, that might be too much stimulation for them. So the idea is that the first stages of some of these, again, you want to try to get them back into their typical activities. So try not to have them do things that are going to give them symptoms. And then the next stage is going to be basically having them do stuff at school, making them do homework while they're at home for a little while. And again, if they do it and they don't have a problem, then maybe you can go back to school for part of the day and then eventually return back to school full time. But the person might need to take breaks in order to actually like rest in order for them to recover. Maybe they can't go all day, go to like a sports practice and then have to do their homework when they get home at night. Maybe something is going to need to give so that they can end up having a break, or maybe they take a nap in the middle of the day. So all of that stuff depends on the individual and how they're actually responding to it. So the other thing that happens is that you start looking at it in these return to school is one thing. The other thing is return to sport. So the idea is that, same kind of thing. It's not exactly the same stages, but again, you want to do not a lot of activity at the beginning and just do daily things, again, brushing your teeth, walking around, going to the bathroom, that kind of stuff, and not have your symptoms get worse. Have your person getting like major dizziness, it would end up being problematic. Then you start doing a little bit of work and maybe start getting the heart rate up a little bit and see whether or not that increases symptoms. And then you add a little bit more aerobic exercise, maybe go a little bit faster, or you can end up having a movement that's very specific to the sport. So again, an example would be running or skating drills. Like little ball drills where, like in football, if you're a receiver where you're just going to catch it, not necessarily doing a full type of passing drill as a receiver, but doing something where you're just catching a ball, right? The non-contact training drills, that would end up being, again, something like passing drills, whether or not it's in basketball, or whether or not it's a receiver running routes, or if it's a quarterback that is trying to throw to a receiver or do different plays. Then you start doing, some practicing without contact, and then you can get into a full contact practice, right? Again, all of these steps should be cleared to make sure that the person can do them. And then eventually you get back to normal gameplay. So that can take a week in order to get back into football after a person does it. And part of the problem with a lot of this stuff is that athletes will try to push themselves beyond what they should be doing, because if you get somebody who is super competitive or a type A type of a person, and they're really just going to, buckle down because it's about, like putting your nose to the grindstone and getting stuff done, that can be a fantastic thing for somebody who is in sport, but it may not be something that's a fantastic thing for somebody who's trying to recover from a concussion. So, and that happens with a lot of other types of things too. You get runners, like on a regular basis that, they think that they're doing a little bit better, and then they take off, and then they end up having some kind of a problem that's associated with trying to get back into something too fast. So again, the things to kind of think about is that the probability of a second concussion is going to start to increase if there's lingering effects from the first concussion. So if you're having that child, like if you're having, like the 17-year-old, try to jog on a treadmill and their dizziness gets worse, there's no way that they should be playing in a game, right? So lasting symptoms of a concussion often occur after the repetitive types of injuries, and you can do different types of assessments of other non-cognitive types of functions. Vestibular function, eye movement, and stuff like that, in order to help to determine whether or not a person should return to play. So again, about 1 to 20% of people end up getting persistent symptoms. Again, the persistent post-concussion symptoms are going to be the same kind of stuff of what we've talked about before: headaches, dizziness, problems with vision and like processing things, one eye being blurry or both being blurry, or maybe your eyes aren't looking at the same place when you're trying to do it. So a person might see double, not that they have like a lazy eye, but if they're going to look at something, if one is focused a couple of degrees off to the left and one is focused to the right, by a few degrees, then you can end up having some blurriness or fuzziness, or start getting into double vision. And that can be problematic. Again, balancing coordination. So all of these things end up having issues. And when you talk about this, again, the thing that's crazy is again, anxiety, depression, irritability, all of these different things, attention, concentration, the memory loss, and all of that. What's crazy is that you start looking at the actual thing. And then again, the percentage of patients that have some of these, and this is from a study, and it's specifically looking at the number of people that have headaches after 1 week, or one study shows that 71% still have a headache after 1 week, right? Some studies show like higher levels of headache after a month, but you start getting into certain levels. And again, it depends on who's included in the study. But in some cases, significant amounts of people will have a headache after 2 years. Significant amounts can have dizziness after 3 months or 4 years, right? So there's a whole lot of stuff that's there. Memory problems that people can have, after 1 year. Again, it depends on how they get their numbers and different stuff like that. But those are big deals for, after 4 years, to people to continue to have memory problems. Again, it's not just a little bit. It's people that end up having, these mild traumatic brain injuries. Again, things can be persistent. So basically the idea is that rest is going to generally be there to help to try to prevent further injury, within 3 days to 1 week. In that you can start to push people a little bit, and you can start to get a little bit of exercise in the brain eventually. But before we talk about that, let's talk a little bit about allopathic treatment. And this is basically what's going to happen with a medical doctor. So, people who are medical doctors, that's allopathic medicine as opposed to chiropractic medicine, where they're allopathic physicians. Obviously, they get called physicians, but you end up having a chiropractic physician, which is going to be doing things a little bit differently. So you talk about somebody that has anxiety, there's medications that you can give for serotonin enhancers. or for people that end up having depression, you can have some of these things like the Prozac and Zoloft and Paxil, which are SSRIs. There's other kinds of things that are going to be people that have insomnia. You can give them medication for that. If you have chronic fatigue, you might be able to give them medication for that. Again, problems with emotion or pain, you can end up giving different things to combat some of the issues. But the main thing is that what it comes down to is that all of those medications can't restore function. That's what it comes down to is that no matter what it is, if the person is having problems focusing, that's not going to be able to like go away. And it's not going to, even when you give the person medication for depression is going to be partly maybe some of the social anxiety, if you're like, or the social isolation could be part of it. And anytime that you end up having a person that ends up having a chronic pain issue, there's always the risk of a person having depression, and they can feed off of each other. But when it comes down to the specific situation with concussion, is that medications are not going to be able to restore the function of the area that's been interrupted or damaged for a little bit. And again, when I say damaged, I don't mean a stroke, but what it comes down to is that there's multiple different things that are associated with that. So what it comes down to, there are other stuff that ends up being problematic or associated with this is that there is this general Hollywood head injury myth, right? Where you end up having, somebody's going down like a road that's closed, and then they end up having some kind of slapstick stuff that happens. But in movies, just in general, the amount of times that head trauma ends up being shown is, significant. Obviously, you start getting into like older cartoons and stuff like that, and everybody's got head trauma. But it's one of the funniest routines that people use because it's there, right? It's funny when someone gets bonked on the head and, they have the birdies twirl around and all that other kind of stuff. Again, that's slapstick. So you can end up having like a Western movie type of barroom brawl, and a cowboy ends up getting punched in the face, and it's, they're hit repeatedly. Someone, gets hit with a chair or a vase over the head, and the person makes a funny face, and then they fall over. Someone gets hit with a liquor bottle. Again, the person collapses, they're completely unconscious, and then the next scene, they're standing up, they're running around. That wasn't an issue at all. Like you've got, James Bond that knocks somebody out, and the person has no problems, like if they just knock them out, right? Or, whatever. So it doesn't matter whether or not it's a detective movie or a boxing movie, or if it's a kung fu movie or whatever, kicks and punches and, different kind of stuff that might be fatal or near fatal that's delivered to the face and the head, ends up being, brushed off, they shake it off, and then they, get back into it, and they give you that look, and, they get going, and then they can jump back into the fight. So that's one of the things that ends up having this as being a problem. I talked a little bit about what happens sometimes with, athletes, where this is kind of how, where people end up getting injured is that, if a coach has that kind of mentality of they've seen that happen multiple times, then it means that concussions aren't that big of a deal. And again, concussions are when they're repetitive and you haven't had the chance to recover, then they end up being more cumulative. And most of the time, people don't end up getting a concussion, fully recovering, and then getting back into it. Usually they're going back in a little bit too soon. So the general idea is that you want to have a patient-centered approach. You want to have a concussion specialist as being the key for the multidisciplinary care. Again, somebody that can communicate with the athletic trainers that are on the team, athletic associations, if need be, any type of case managers, if you're talking about like workers' comp or any of that other kind of stuff, school boards, again, workers' compensation types of stuff, multiple different things in order to advocate for the individual. And the people that would be a good person for a concussion specialist, one of them, and this is obviously going to be me being biased, but one of them is going to end up being a chiropractic neurologist. So someone who has training in chiropractic neurology or functional neurology is going to be a good person to evaluate the problem and then try to help make the problem go away. That's not saying that a medical neurologist isn't a good person to do that. They're going to have a little bit of a different approach. And they're definitely going to be somebody who would be able to help with any drug interventions. But as I said, most of the time for the medical neurologist, the way that it's going to be is that the person is going to end up getting an exam, and then they're going to be seen, you know, a few weeks later, and then they'll have another quick exam and they'll just monitor, did they get better or not? Which that's not helping the person actively. It's helping monitor the situation, you know, but it's not helping to make it go away. And in a lot of these cases, you can make it go away actively by doing a little bit of work. So again, neuropsychologists are sometimes used. People sometimes go to occupational therapy, you know, so there are a handful of different things that can be done. So when it comes down to it, you know, what's the solution? Really what it comes down to is, like we said, rest is going to be effective to help to get rid of any further injury within, you know, somewhere between 3 days and a week. But active rehabilitation is going to be necessary for people that don't respond to rest, especially within 2 weeks. And, you know, even more for those after 45 days. So again, about 10 to 20% of people who end up having concussion have not responded to rest within those 2 weeks. And about 2.5% of people who end up getting a concussion haven't responded after 45 days. The people can help, you know, you can have some cognitive rest that might be helping to speed it up. But if they're not pushing things at all, then they can end up having problems. So there's some evidence that basically shows that vestibular and oculomotor rehabilitation combined with cervical rehabilitation is the most effective. So what that means is that you have the inner ear that's going to be, it does sound, but it's also going to be telling your brain where your head is, or if you're leaning to the left or you're turned to the right or any of that other kind of stuff. Your vestibular system does that, but your neck does that as well. And a lot of times when people end up getting trauma to the head, they end up having trauma to the neck. And the trauma to the neck is going to end up being something that there's problems with your brain knowing where your head is. So people that end up having some of these different problems don't know, like, if they're looking straight ahead or if it's a little bit off to the left or off to the right. So you can literally take somebody, blindfold them, put a laser on their head and have them point it at a spot on the wall. And if you try it a couple of times and you do it with their eyes open, you say, okay, look all the way to the left. Now look, now bring the laser back to this dot on the wall. Now bring it all the way to the right and bring it back to that specific spot on the wall. Try it a couple of times. And then now do it with your eyes closed or with something that's basically blinding you to see whether or not you're actually on target. A person that doesn't have any pain should be able to be pretty much dead on with that, with knowing where things are for their neck. Person that ends up having neck pain, or if a person ends up having whiplash, or if a person ends up having a concussion that has a cervical problem associated with it, then they're not going to do a good job at knowing where their neck and their head is in space. So over-the-counter medications can be helpful with some of the symptoms. Some of the prescription medications can help to address some of the, like the psychiatric type of challenges or, you know, different stuff like that. But really what it comes down to is that you need to do some of these rehab systems or rehab programs needs to be involved. You know, basically the person needs to be sub-symptom threshold. So you want to do sub-maximal exercise. So not push the person until the point where they end up having a worsening of their headache or a worsening of like the nausea or whatever, but it's stressing things, but not going too far. It's a little bit without breaking the person. And if you're constantly doing that, then the person ends up adapting and things start to get better and better and better. So there's multiple different things that are associated with that. So basically what it comes down is that you want to try to take care of some of the issues, right? So if you talk about like the neck in and of itself and the head in and of itself, You have to put out the fire. You have to take out some of the inflammation, some of the problems that are associated with it. So you need to basically put out the fire, make the brain fireproof by doing what you have, and then you have to deal with the injuries to the neck. So you have to put out the fire by all the inflammation that might be associated with it. You need to strengthen the neck and strengthen the brain so that the brain does a better job. And then if the person has any injuries to the neck, then that could be something that can be helpful. One of the things would be chiropractic adjustments. So adjustments to the neck is something that is very effective at helping people get over some of these problems. But in some cases, that's too much, because a chiropractic adjustment is very much stimulating the spine. And if you stimulate the spine too much, then a person can get overloaded. It's like, imagine somebody who is just concussed walking down the street in Vegas on the Strip. They end up getting so much movement, so many people, flashing lights, too much sound, all that other kind of stuff. They end up getting overloaded. Same kind of thing can happen if the person gets adjusted in some cases. So you do have to be careful. There's going to be things that are soft tissue types of therapies that are going to be done for people. So one of the things that I'm certified in, and I'm the only person that's in the area that is certified in this, I'm technically a Graston technique specialist. So there's, this is one of the different kinds of things that you can have, but Graston technique is fantastic because you can use these metal tools to kind of get in on certain areas. And if you, by working out and digging into the neck and the areas that end up being problematic, you can end up helping to detect and treat areas of scar tissue that you might have, or chronic inflammation that might be there in a muscle or a tendon. You can basically work out the connective tissue in order to basically start to treat the area, prevent scar tissue, prevent scarring up of the things, help to fix some of the trigger points and radiating pain and other kinds of stuff. And it's something that is extremely effective at helping people feel better and loosen up. Again, people can report pain reduction like immediately. It's very often that people will feel a little bit better within the first couple of treatments. So that's one of the options that people would have. So when you're coming down to it, you want to try to figure out what the issue is. And there's different ways that you can look at where the problem is. Is that, is the problem in the spinal cord? In concussion, it's not going to be in the spinal cord. It's not going to be in the nerve. It's not going to be into whatever is sensing it. So the end organ is going to be the thing that is sensing things, and it's going to be going out and coming back in the other direction. So, the receptors in your eye are going to be for the visual system. Those photoreceptors are going to end up being one of the things that that starts the process. And then it comes back in through a peripheral nerve. In this case, it would actually skip the spinal cord if it was the eye, and then it needs to be integrated in the brainstem and then associated up with the cerebellum. So the cerebellum is going to be one of the coordination areas of the brain. So the brainstem and the cerebellum are going to work hand in hand. And people that end up having issues with concussion typically are going to have problems in the brainstem. They're going to have problems in the cerebellum, and they can have problems in the cortex. So there's a whole handful of different things that are going to be there. So when it comes down to it, therapies are going to be something that can target very specific regions of the brain. And that's one of the ways that you want to try to do what it is that you can. Different areas of the brain do different things. So you want to have the therapies target the different areas of the brain that are maybe not working as well as they could. So if you can objectively measure what's going on, then do that. You can find neurological deficits, and it could be something that's, a little bit, more distinct, or it could be something that maybe is not a little bit more subtle, right? You need to be able to understand the functional relationships within the different areas of the brain. And you also need to be able to go through and apply some of these strategies to the areas that are weaker or problematic, and use those different things in order to increase their strength. And basically, by doing brain exercises over time, strengthen the brain to get back to what's normal so that it can do its normal functions. So some of the things that can be used by a chiropractic neurologist, and again, So obviously, these are going to be things that are going to be used by other healthcare providers as well, but we have the tendency to do things maybe a little bit differently. You know, blood pressure is going to be the same. You're looking at heart rate. You're looking at the amount of oxygen that's in a system, temperature, and whether or not it changes in, associated with position. So the autonomics and how a person is going to be processing things is important. Another thing that is typically not going to be used in a lot of cases is going to be looking at the eyes, right? What do the eyes do? You can get, tools like this. This is one of the things that I have in my office, where I've got little cameras that are here that I can actually record a person's eyes and then see what they look like. And then you can compare them over time to see how the person has improved with their eye movement over time. So you can do it in this case. You can actually even cover the person up and have them do things in the dark. You can see their eyes. It's in the dark. It's actually, they're using infrared. So it's black and white on the screen, but they're using a light, like there is a frequency of light that you can use where you can't see, but the camera can see. And then that is going to be something that is basically shined on the person, and then you can see what's going on. So you can do it with them covered, them holding still, smooth tracking with their eyes. So if you look at the thing that's here, when I move this across, if I'm moving it the right way, everything is moving basically continuously. If I was to go back here, and if you were basically to, it could be something that's more jerky like this. When I go that far, when I go, from here all the way to here, again, your eyes are going to be able to jump from one place to another. So how well does a person's eyes jump? How fast do they jump? Are they moving really quickly when they move over? Or when I do this, is it 3 seconds until you move your eyes? Right? So there's ways that you can track the eyes to see whether or not the person ends up having problems, right? You can do movements with the head to see whether or not the eyes are doing things, or even if the eyes are rolling in the head. And this would be an example of what it looks like, when a person is using these real eyes monitors. So you can actually see the eyes up close, in that, and you can see the dilation of the pupils and different stuff. Again, you can see in this picture, her pupils are really dilated because she's in the dark, right? There's different types of balance boards that you can use as well, where you can actually do different things and have a person do different types of movements that might show how well their balance is. So you can move the head in a specific position. If a person is balancing, you have the person stand basically with their feet together. There's going to be a little bit of sway front and back. There's going to be a little bit of sway side to side. If you do that, you can actually check and say, like, okay, well, how was your balance there? Now I'm going to have you take your head and look all the way up at the ceiling. So now some of the vestibular system is going to be, it's going to be maybe complicated at that point. So it's not going to maybe work as well. So the person might have a problem. You can have them do it with a pad like this that causes things to maybe not work quite as well, or you can do it without the pad and make it so that it's a little bit easier for people. You can have them do it with their eyes open, standing on a pad, with their eyes closed, and then with their eyes closed, standing on a pad. And it should be a lot worse with your eyes closed, standing on a pad, because you don't know exactly what's going on, and your brain isn't getting maybe as much feedback. So that's one of the things that you can also do to kind of monitor progress. So you can actually check that and see that should improve over time. Okay. Other kinds of things that you want to look at is, what are the therapeutic tools that a person can use? If all you end up having is, this is one of those kind of things where, like, in your toolbox, if all you have is a hammer, then everything looks like a nail. So if the only thing that you know how to do is prescribe medications for stuff, you can cover up symptoms, and you can help to, maybe help the person live their life and not get overloaded. But what it comes down to is that maybe it's not hitting all of the different spots that you need to hit, right? So when it comes to how you do some of this stuff, is that you need to exercise the brain. So you exercise the brain using very specific types of techniques. So you can affect a person's taste, and that will affect the brain. You can affect smell. You can try to affect their sight. or what it is that they're seeing or how they're processing their sight. You can stimulate with touch or movement. So that can be some of the Graston, like what I mentioned earlier. It can be adjustments. There can be hearing types of therapies that you can do. And again, vestibular information. So when it comes down to it, that sensory motor training that a person would do, the sensory motor training is working on the visual system, working on auditory, working on motor, and then trying to synchronize everything together so that it works the way that it's supposed to, making sure the different areas are coordinating, because again, that is something that is very important for the brain to do. Again, multiple different types of attention, taking the attention and focusing on one thing, or making the person focus attention in different areas. Moving the eyes, working on the cerebellum, and trying to coordinate, do new types of movements can be beneficial. Working on the vestibular system in order to improve the person's balance if there is a problem with how the person is processing and feeling pain. And then the other thing that you end up having is that you end up getting there's neurovisual training, which, that is something that is a wide, thing. Lots of different information that's there, but you also, when you're doing that, a lot of times you can end up processing things and have the person's brain work a little bit better. So there's multiple different things that are associated with that. That is about it. There's a couple of different versions and a couple of different things. If you have any questions, obviously leave them in the comments down below. I definitely appreciate you taking the time to join me today for this lecture on concussion and the care that's associated with that. And like I said, reach out to me if you have any questions, and if I can be of any help, I'd love to. So have a good night, and I will see you later. Bye-bye.